This is Mark William Rolfe, Associate Professor of Internal Medicine and the Medical Director of the Adult Cystic Fibrosis Program at the University of South Florida School of Medicine, Tampa, Florida. Flexible fiber optic bronchoscopy is a procedure routinely used in the evaluation and diagnosis of airway diseases. It has been used extensively in clinical research into lung disease. In the situation you are about to see, bronchoscopy is being performed on a 26-year-old patient with cystic fibrosis. The patient is undergoing this procedure with the vest in place. After topical analgesia and intravenous sedation is administered, the bronchoscope has been advanced through the posteropharynx, through the vocal cords, and into the left lower lobe bronchus. The small insert frame in the lower right-hand quadrant of the screen shows a main carina and proximal airways as the bronchoscope enters the left lower lobe. The airways are mildly to moderately inflamed. The main screen image depicts airway secretions as the vest is activated. The oscillations of the vest are seen as they are transmitted from the chest wall through the lung parenchyma and into the airways themselves. Almost immediately, mucopurulent secretions are seen to well up from the lower segmental bronchi. The secretions ebb and flow from these bronchi with the patient's spontaneous respirations until a cough expels the secretions into the left main stem bronchus, temporarily obstructing the view from the bronchoscope. Once these secretions are cleared, more secretions are then seen emanating from the lower lobe segmental bronchi as the transmitted oscillations from the vest continues. Airway clearance is rapidly being recognized as an adjuvant to standard therapies in a number of respiratory diseases. With changing lifestyles and an aging population of patients, alternative self-directed modalities of chest percussion have been developed, including the vest from Hillrom. The film demonstrates the mobilization of airway secretions following the activation of the vest. After providing upper airway anesthesia with nebulized lidocaine and gentle conscious sedation with Versed and fentanyl, a fiber optic bronchoscope is advanced through an oral bite block into the trachea to the level of the main carina. In sequential fashion, the left and then right tracheobronchial tree are examined with findings of scattered mucopurulent secretion, notably adherent to the mucosa of the airways. Next, the bronchoscope is positioned at the main carina, the vest is started, and the exam is repeated. Copious amounts of thick secretions are seen emanating from the segmental bronchi as oscillations of the vest can be visualized in the airways. On several occasions, thick mucoid plugs are mobilized into the main airways, obstructing the airways and the view through the bronchoscope. Suctioning is required to clear the airways and reestablish visualization. After examining the right tracheobronchial tree, the fiber optic bronchoscope is withdrawn and re-advanced down the left tracheobronchial tree, demonstrating continued accumulation of secretions during the examination of the right side. This demonstration clearly shows the efficacy of the vest in secretion mobilizations in the airway of a patient with extensive bronchiectasis and airway secretions. The vest is safe and effective to use with or without bronchoscopy in a variety of patients, including patients with cystic fibrosis, post-thoracotomy patients, and potential lung donors.